Hey my future RNs, this is our next video in our ECG interpretation series. We're going to take a look at sinus and atrial rhythms. Okay, welcome to EKG or ECG interpretation. We're going to focus today on sinus and atrial rhythms. Here are our learning objectives. We're going to review the steps of analyzing ECGs. We're going to apply those steps into the various sinus and atrial rhythms. And we're going to review some clinical manifestations, disease states associated with those rhythms. Okay, so we have the steps for analyzing a rhythm. Please note, I do have a more in-depth video that goes through each of those steps and shows examples. So if you have an opportunity, please click and watch that video. Step 1, we want to determine if the rhythm is regular. Step 2, we're going to calculate the heart rate, and we're going to be using the rapid calculations for analyzing these rhythms today. Step 3, we're going to examine the P waves, which indicates to us that it's a sinus rhythm. Step 4, we want to measure the PR interval. And step 5, we want to measure the QRS complex. So let's practice. Here is our first rhythm. Remember the steps. So we want to determine if this rhythm is regular. So how we do that, we're going to measure between each R to R wave. And so far, it's looking regular. Next step, let's calculate the heart rate, okay? So in a 6-second strip, we want to count the R's and we would multiply that by 10. So is it between 60 and 100? For this rhythm, it is. Step 2, look at your P wave. So take a look at each P wave. There should be one P wave in front of each QRS complex, and they should be identical or near identical. And this rhythm meets that criteria. Step 4, let's take a look at our PR interval. Is it between 0.12 and 0.20? Is it between 12 and 20? So we want the maximum of 5 small boxes for your PR interval. And this also meets the criteria. And then the QRS complex, it's about a box wide, 0.04 seconds. So that still also meets the criteria. So all of our criteria is within normal limits. Heart rate is 90 beats per minute. Our P waves are present and upright. The PR intervals within normal limits, and also the QRS. So if it walks like a duck and quacks like a duck, it's a normal sinus rhythm. So normal sinus rhythm is the general scale that we use to measure regular performance of the heart. Also note there's some physiological changes in heart rate. As an infant, your heart rate could range from 120 to 160, and as you get older, the heart rate starts decreasing. So just keep in mind there are various circumstances where that heart rate would not fall between that 60 and 100 range. Okay, so here's our next rhythm. Okay, so we're gonna put up our steps. So let's determine, is it regular? So according to this rhythm, it looks like it's regular. The R to R distance is approximately the same. So remember, you have about a 3-box difference to say that it's regular. Let's look at our P waves. There's one P wave in front of each QRS, and the P waves are near identical. And let's count our R waves. Let's calculate our heart rate. And we have about 5 R waves, and this is a 6-second strip. Our PR interval is within normal. I'm counting about 5 small boxes. And our QRS complex is about 2 boxes wide. So everything is normal except the heart rate is less than 60. So how would we interpret this rhythm? This rhythm is a sinus, because there are P waves, bradycardia. So the only thing out of normal range is the heart rate. So sinus bradycardia. can be actually normal variation. Take, for example, the trained athlete, okay? His heart rate, because his heart is so efficient, will be lower than normal, okay? But other things that could decrease our heart rate include carotid massage or that Valsalva maneuver when you are bearing down, pushing, that slows down the heart rate, and certain medications will decrease your heart rate. So just keep in mind certain diseases like hypothyroidism and MI can decrease your heart rate, especially if that upper atrium was damaged during the MI. It can affect the sinus node. If you have increased pressure in your brain, that will slow down your heart rate. So just note, if you have symptomatic bradycardia, the treatment for that would be atropine. And when I say symptomatic, if your heart rate is low to the point where it's affecting your blood pressure, it's symptomatic. So atropine would be the treatment, and also a pacemaker could be required that would take over the job of the SA node to get that heart rate beating at a normal rate. Let's look at our next rhythm, okay? Here are our steps. Is this rhythm regular? And we're gonna count our heart rate, okay? So yes, so the R to R waves are regular. Our heart rate is 130 beats per minute. We have one P wave in front of each QRS. The PR intervals are within normal limits, less than 5 boxes. And our QRS complex is nice and small, about 1 to 1.5 box wide. How would you interpret this rhythm? It's sinus tachycardia. So basically the SA node is firing at a rate more than 100 beats per minute. Okay, so sinus tachycardia, it could be due to exercise, fever, pain, hypovolemia. If you're losing volume, your heart will start beating faster to compensate. Anemia, if you have a low blood count, hypoxemia. So all things can manifest itself in a rapid heart rate. Now, hyperthyroidism would cause tachycardia, and we have anxiety, and also certain drugs can cause tachycardia. Treatment for sinus tachycardia would be based on what's causing it. Okay, so if it's a drug, we're going to stop that drug. If it's a fever, we need to bring down the fever. So the treatment depends on the underlying cause. So here's our next rhythm. Here's a reminder of the 5 steps. So pause this video if you need some more time to take a look at it. So is it regular? So based on the arrows, it's not regular. So let's look at the P waves. We have a few P waves that are identical. We have one P wave in front of each QRS, but there's one P wave that's inverted. So all the P waves are not the same. But we don't want to judge the whole strip by one mistake, if you want to call it. Our baseline rhythm, so we have the first 2 complexes are within normal, and the last 2 are within normal, but something happened in the middle. So we have an irregular rhythm, but the base rhythm is basically regular. The P waves are not identical. Our heart rate is 60 beats per minute. The PR intervals is within normal limits, and the QRS complexes are within normal limits. This rhythm is what we call a premature atrial contraction, or PAC. Okay, so that rhythm complex with the inverted P wave, that is our premature atrial contraction. But you definitely don't want to just label the whole rhythm as a PAC, okay? So we would call it normal sinus rhythm with a premature atrial contraction. So you don't want to judge the whole rhythm as a PAC. You want to note the baseline rhythm, which is it's a normal sinus rhythm, and we have one premature atrial contraction. So premature atrial contractions in a healthy person, an isolated PAC here and there is not really significant. It could be caused by emotional stress, fatigue, if you drink too much coffee, if you just smoked a cigarette or vaped, you could get a premature atrial contraction. It could also be due to electrolyte imbalance. Some disease states would include hyperthyroidism, COPD, heart disease or disease of your heart valves. And the treatment, again, just like your sinus tachycardia, would depend on your patient's symptoms. Okay, so here's our next rhythm. So remember the 5 steps. This is a place where you could start. You want to determine if it's regular. We're going to calculate the heart rate. Then we're going to look at the P waves. We're going to measure the PR interval. And then we're going to look at the QRX complex. So looking at this wave, you can measure between R's. It is pretty regular. Okay, so if we take a look at the heart rate, we have about 17 R waves in this 6-second strip, 17 to 16 R waves. So the heart rate is about 160 beats per minute. Now let's look at our P waves. So where's the P waves? Do you see a P wave? We do see something in front of the QRS, but is it coming or going? Is it a P wave or is it a T wave? You can't really tell. That is the key thing with this rhythm. So do we measure a PR interval? We're not sure, but we do know the QRS complex is within normal limits. Our heart rate is regular, rhythm is regular. Your heart rate is about 160, so it falls between that 160 to 250. So there are P waves in this rhythm, but you can't see them because the rhythm is going so fast, it's hidden within the T waves. So because of that, you cannot calculate a PR interval. This rhythm is called a Proximal Atrial Tachycardia, or PAT for short. It's also known as supraventricular tachycardia, or SVT or PSVT. Okay, so that's the key. Once it goes past 150, 160 beats per minute, the rhythm starts shrinking, your P waves get swallowed up into the T wave. You can't identify a P wave, but it is coming from the sinus node. It's just so fast that you can't see the P waves. PAT, SVT, PSVT, however you want to call it, it can be caused by severe emotional stress, physical fatigue, or even caffeine, electrolyte imbalances, or hypoxemia. But the key thing is not to have this rhythm go on for too long. Hyperthyroidism, chronic obstructive pulmonary disease, COPD, heart disease can cause SVTs. Treatment for SVTs would include electrocardioversion. If the patient is unstable, you could give them sedatives. Physician could perform a carotid massage to slow down that SA node from firing. You could have the patient do a vagal maneuver. You can also use adenosine, 6 milligrams, and repeat 12 milligrams if the first dose doesn't work. Other drugs such as calcium channel blockers, beta blockers, or digoxin can also be used. So here's our next rhythm. So remember your steps. Is it regular? Heart rate. But what's going on with the P? Where's the P? Can you identify a P wave? So in this rhythm, you can't. You do see the atrial baseline is something's going on there. So what is it? So this picture shows nicely what's going on. The SA node is firing and is kind of bouncing back and forth inside that atria before it goes into the AV node. So what we call this is a flutter. There's not a specific P waves. There's not one P wave in front of each QRS. Atrial baseline is fluttering, or it has that sawtooth effect. So this is our atrial flutter. This is easy to memorize. You could see that sawtooth effect. This is atrial flutter. So atrial flutter can be caused by hypertension, valvular disease, pulmonary embolus, any kind of lung or heart disease. Drugs such as digoxin or epinephrine can be a cause for a flutter. Increased risk of stroke. Because that atrium is not contracting efficiently, it's kind of shaking, it increases your risk for stroke. And also note that high ventricular rates is considered unstable. So you could be in an atrial fib or atrial flutter and your rate is within normal. That's considered a stable A flutter, and that person would be on an anticoagulation to prevent thrombus. But if the ventricular rate is high, that's something you definitely want to stop. So a brother of A flutter is here. So let's start. Is it regular? As you can see, this rhythm is very irregular. Our heart rate is about 50 beats per minute. We cannot identify a P wave because the atrial baseline is just shaking, just trembling. Everything else, we cannot calculate our PR interval. Our QRS is nice and small. This is a good picture that identifies what's going on. The impulse is coming from the SA node and it just bounces all over the walls. So it's chaotic, unorganized. This is atrial fibrillation. It's just a shake. So just look at the difference between atrial fibrillation and atrial flutter. Flutter is more organized. It's more defined. It's more detailed in the rhythm. A flutter can be regular or irregular. So if you have 4 flutter waves in between each R wave, you're going to have irregular rhythm. Atrial fib is always irregular. So just take a look at these pictures to help you solidify in your mind the difference between AFib and A flutter. And sometimes the patient could have both. So just like our A flutter, AFib can be caused by rheumatic heart disease, CAD, hypertensive heart disease, heart failure, pericarditis. Can cause atrial fibrillation. Alcohol intoxication, caffeine use, electrolyte disturbances, stress can all cause atrial fibrillation. Just know atrial fibrillation, if again the ventricular rate is high, can decrease your cardiac output and it puts you at high risk for strokes. So you definitely want to make sure this patient is on some kind of treatment to prevent strokes. And there you have it. I want to thank you for watching and check out our next video.